The peer-to-peer mechanism of action. In vivo, the application of PRP gives the activation of endogenous collagen, and after that we have the release, a cascade of growth factors and cytokines that allow for stimulation of local stem cells, extracellular matrix veins, as well as allow for inhibition of excess inflammation with apoptosis and MMPS. And the final step is the regeneration of tissue. But PRP used in rotator cuff repair. Despite the compiling rationale, we got no benefit at all. In bone pathology, despite the compiling rationale, no benefit in a non-union and as well as in complicated fractures. I used that. This is one of the cases for which I tried to treat a non-union of clavicula by resorting to PRP, concentrated PRP. You can look at the site of the union, and after the stabilization, we stabilize with 3 or 4 QI, and this is the PRP, the concentrated with the slight gel, and that is used to fill with bone pasta at the DBM in order to fill completely the zone. Repair has been got at 3 months from surgery. And what about the PRP used in bone pathology? It has been used as catalysator of tendon bone integration in ACL reconstruction, or we start to use in cementless hip implant arthroplasty to try to resort to a form of resurfacing of the implant, the tendon implant, in order to enhance bone integration. But usually the most important situation that we generally manage is ACL reconstruction with resort to growth factors, and in order to give early return to sport. We have performed a study, and the objective of the study was to clarify if growth factors play a role in anterior cruciate ligament reconstructive surgery. 20 patients with laxity caused by Chiron ACL underwent arthroscopically assisted reconstruction with hamstring tendons. We performed a prospective study with this patient randomized in 2 groups: growth factors group, so that patient treated with growth factors, and the control group in which patient was treated without growth factors. These are some steps that you can see for hamstring armstring and hamstring rolling, in order to be completely covered with the PRP that you have just used at the level of the bone tumors. And the second look at 3 months follow-up give us this kind of results. Second look arthroscopy as well as NMR show a statistically significant difference between the 2 groups. In ACL, the density of the 2 groups, the growth factors group, ACL density is similar that of the posterior cruciate ligament. So that growth factors could accelerate the integration of the new ACL in the femoral as well as in the tibial tendons. But give me the possibility to explain the important limitation in the use of PRP. Efficacy and uniformity of preparation are very, very important. PRP procedure is a wide variation of platinum numbers, different preparation methods, inter-individual variability, age variability are very, very common situation. But if you look at the PRP procedure, you can verify that you have four different types of PRP. Pure PRP, as well as leukocytic PRP, as well as pure platelet-rich fibrin, as well as leukocytic platelet-rich fibrin. All PRP treatments are the same? No. No, because one treatment is not the same as another treatment for different reasons. Platelet level base is different in every patient. There are different types and use of PRP, liquid, drug, foams, and so on. And some treatments contain red as well as white blood cells, thrombin, calcium chloride. Conclusion. The constant term is acceptive because patient ounce blood is used, limiting the potential for disease transmission. But major limitation to the predictability of PRP as a therapeutic modality give us this answer. The composition of PRP varies from patient to patient and may also vary with the different devices used to preparate and to the time and method of storage until it's used. So, when an injury occurs, platelet release factors within the clot appear, and we have a necessity to stimulation of the equipment mesenchymal stem cell to the site in order to promote proliferation. These factors reduce inflammation and stimulate angiogenesis. The major components of PRP include this factor we have just seen a lot, and additional factors are needed for stabilization of neurovasculature. But PRP must be considered in this way only as an adjunctive therapy for the specific application. So, early on, PRP was used as an additive for bone graft and bone graft substitutes. But the MPS are found in the clot, but it is insufficient level for the clot to be osteoinductive. Neither is PRP by itself osteoinductive. Moreover, it's able to inhibit both the inductive properties of the mineralized bone matrix, as well as osteogenic effect of BMP on osteoblast-like cells in vitro. And this is the explanation for which PRP has not been effective as treatment, for instance, for spine fusion. So, in conclusion, our recent studies suggest us that PRP may have potential in orthopedic application where enhanced angiogenesis and vasculogenesis are critical. And this is particularly the case for tendon repair. The mechanisms all are not known, but one study or several studies suggest that the improvement is due to an increase in angiogenesis because of factors as well as FEGF in the PRP. The use of this device helped to reduce variability resulting from processing, but not variability due to donor differences, to the length of the time involved in collecting patient blood, in concentrating platelet release, and preparing the material for implantation. So, actually, we can only suggest that PRP may be valuable in enhancing soft tissue repair, particularly for tendons, and in wound healing. And the clinical role of PRP in bone repair remain completely controversial. PRP is not uniformly successful as an adjunctive bone grafting procedure and might promote or inhibit bone formation, depending on quality at the setting in which it is used. Although all PRP preparation contain the basic set of factors, growth factors, The proteses with platelet release may degrade some of the growth factors, reducing the availability of biotical factors, changing the composition of PRP, and altering its clinical effectiveness or specific application. And this should be results of the donor difference in PRP composition. The future of PRP expanded role in the treatment of many conditions and adjuncted and adjunct to the healing in the care of cognitive and muscular disease. Future use probably involve stage biochemical manipulation of the healing and interest particularly the inflammatory process. Thanks. I know that it has been a boring speech because we have spoken about theories and some features, but these features are fundamental in order to go to further speech. We go and deep in order to explain exactly the great possibility of application in orthopedic fields of this kind of tools. Mesenchymal stem cells concentrate. Mesenchymal stem cells concentrate. Mesenchymal stem cells after bone marrow concentration are, according to the experience of mine, fundamentally because they today has a role that in the present is fundamentally, but should be dramatically increased over time, and within 5 to 10 years should be able to replace at best most of the solutions that actually are managed only by resorting to mechanical device or implant artificial device. As I stated before, I'm very interested in implant arthroplasty. This is my field, is one of the most important fields of my career, of my field, due to the fact that I'm fond of this. And I'm a consultant of the most important orthopedic company. I'm first consultant of Zimmer as well as Dupuy, J&J, as well as Smith & Nephew. And as consultant, I'm in charge of study and try to accompany bioengineering in order to realize a new system and in order to use them as a first user in order to verify the ability and the possibility of these tools. But the demand nowadays is completely different. Today, patient, and we are speaking about fundamentally the young patient, needs more and more. And they ask for the best result, and they do not accept any results that is not like a complete healing. Now experience fundamentally made in Italy, but that has spread over in Russia as well as in other countries in which I do my practice. I've seen that young patients are high demand patients, so that and when patient is so young, you try to resort to the best solution, not by substituting a part of his joint, by trying to resurface the tissue and try to restore the defect that he has sustained. So that my practice moved to a mixing of solution in order to arrive to a complete biological reconstruction. And you will see in the next speech that I passed by from a complete biological solution to any biological solution with different kinds of implant partial resurfacing arthroplasty in order to get an answer to the demand of these young people that want only one thing, want to restore at the best his quality of life. Well, if you have a chance, we have the possibility to introduce our friends, Randy, in order to explain some of the features of the stools. After that, we have just a bit time in order to get discussion. After that, we have time for a coffee break.
Okay. Okay, guys. Thanks for taking your time. Like I said before, again, my name is Randy Beimel. My job has been to introduce our product to the global market. Very simply put, I had mentioned before, over the last 12 months, we have done some extensive research through Europe, through the UAE. At the same time, we have introduced our product with our FDA approval. So we've done distribution in the United States over the last 12 months with a lot of success, and we're really happy to be here with you guys today. So what we have seen is a massive, let's just call it an explosion in the regenerative medicine. So a year ago, when we first started talking about our product using bone marrow, it wasn't as popular as it's getting today. Now, what we have seen and what we've been working on is trying to bring stem cell therapy to a minimum invasive, non-surgical procedure. Now, what we've seen over the last 12 months just with PRP, I'm sure a lot of you guys are doing PRP in your offices every day, okay? The most attractive part of doing PRP is you can do it in your office. It takes about 20 minutes, and you can bring the patient in, you can pull the blood, separate the blood in your centrifuge or what machine you're going to use, inject the patient, and he goes out the door. Okay? But we realize that there's much bigger healing factors in the bone marrow itself than from the whole blood. Okay? Our problem has been the only time that any of you gentlemen have an opportunity to be able to harvest bone marrow over the last several years has been by using this device right here, the jam sheet needle. Okay? This particular needle was developed, patented in 1972. We didn't do stem cell therapy in 1972. This needle was designed specifically for harvesting bone marrow for biopsies, and you would take the product and you would dispose of it. But here we are, pretty long time. 1972, we're looking at almost 42 years, where we're using the same exact device that we used back then. Only now we have much different reasons why we're using it. So what we have done as a company is we have identified everything that is wrong with this device, and we've made it better. Okay? So the first thing that we realize is the only time that any of you men are going to use this particular product, this needle, is when your patient's already in the operating theater, you already have them under anesthesia, you're already doing another medical procedure, and it's this time that you would be able to do some type of aspiration of bone marrow, to use bone marrow concentrate to be able to help heal your patient. So what we have said to ourselves, we said, look, first of all, when we insert this needle into our patient, primarily we're going here in the iliac crest, right? When we're pounding it in, we are microfracturing the bone. That microfracture of the bone is creating bone bruising, which is going to cause discomfort for your patient. Not right now because he's sleeping, but tomorrow when he wakes up, he is going to know that he had this needle in his hip. Okay? Now what we're also finding is because of the microfracture, we're getting tiny bone fragments in the marrow itself. So what we're getting is we're not getting a pure product. We're actually getting a product, okay, that isn't 100%. So what we have said is the first thing that we should do is identify a different way to be able to insert the needle inside the human body. So what we have done, just keeping it in a simple carpenter mindset, we've taken a power-driven drill. Now, we sent a lot of you guys some information. You may have seen some of the instructional videos. But simply by taking a typical normal drill that you're putting a screw in already, we've been able to eliminate the microfractures in the bone. No microfractures means no bone bruising, which means tomorrow the patient's not going to really realize that you put it into his hip in the first place. So the first thing that we've been able to do is that we've been able to make the procedure more simple for you, but also we've been able to reduce the pain for the patient 80-85%. Okay? So that's the first thing that we did. Now, more importantly, and one of the biggest reasons why you guys want to be talking to us today, is we said to ourselves, if we know that by introducing stem cell therapy to the healing of an injury, our patients have a better opportunity to heal faster. Could be as much as 70% faster. So what we said to ourselves is, if we realize that by doing it during the surgery, it's going to help our patients heal faster, why aren't we trying to use stem cell therapy for preventative medicine? Why aren't we using the stem cell therapy in a rehabilitative way? And the answer always came back that if you're using bone marrow to be able to get your product, and this is the only way that you have of aspirating it, I mean, guys, we're not going to bring our patients back in the operating theater to use the Jamshidi needle to be able to get bone marrow to do a procedure. So what we have discovered is we're able to go ahead and draw from the tibia. Now, the reason why this is significant is that because we're drawing from beneath the knee, we're not using anesthesia. We're using a local anesthetic, and we're able to do this procedure in the doctor's office or in your outpatient facility. And what we've been able to do is we've been able to streamline the procedure to where within less than 1 hour, in a point of care situation, we are able to bring the patient in, aspirate the bone marrow, we'll separate it in our centrifuge, we'll inject the patient just like a normal PRP procedure, and the patient will drive himself home. Okay? So this is where our mindset is and where we have ourselves going to. And so we see ourselves as just from what we have done. We have different partners of ours that are doing PRP. Tuesday could be PRP day, and you could bring in 35, 40 patients into your office. You can do the procedure and you can send them on the way. But if you are actually trying to do bone marrow, your entire day is filled in the operating theater. So what we're able to do now is we're able to do 20, 25, 30 procedures in your office or your outpatient facility using only a local anesthetic, but yet we believe that you're going to have a product that's going to be at least 10 times better than just using normal PRP. Okay? So what we have is let's get ourselves, stretch our legs a little bit, get ourselves a coffee break. I have some samples of our product if you want to take a look at it during the break. If you have any questions, you can ask myself or Professor Zanassi. Okay? And then we'll go from there. Okay, guys, let's take a break.
This brief coffee break. We go forward to main step to the core of the speech. Previously, we have spoken only about theory, but now we can deeper in the core of the fields of bone and cartilage reconstruction while sorting to mesenchymal stem cells. The treatment of bone defects and bone healing disorders is considered one of the biggest challenges in orthopedics and trauma surgery as well. And we can verify, in animal experiments, the direct transplantation of mesenchymal stem cells precursors is able to lead to osteoconduction. And the clinical results of the transplantation in management of cases of osteonecrosis as well as bone union have shown first promising results. So far, cell-based therapies for bone generation have only propagated to a limited extent due to considerable logistical time and efforts needed, and the complicated labor constraints that are actually in many countries, as in Italy, for example. In the meantime, however, approved autonomous cellular preparation systems are available for human use, which allow quantitative level relevant purification concentration of molecular cells for bone marrow aspirated directly in operative filters. So far, the object of the present speech is to try to record a complication and to evaluate some clinical results in patient immunotherapeutic autologous biomarker with mesenchymal stem cells are being used. What about stem cells in bone healing? The current standard treatment for significant fractures is linked to first surgical fixation of the fracture with hardware. That should be nailing or plating or what you want in order to stabilize at the best the side fracture. And the current standard treatment for bone defects is to try to resort to bone allograft that have been used for over 50 years to heal defects. But when you have to manage defects that are greater than 5 centimeters, The failure of this graft can occur in up than 60% of patients within 10 years from surgical procedure. If you move faster to the bone size of the fixing fracture or the healing of the fracture, we, all of us, knows very well that there are three main steps. Stem cells turn into cartilage-forming cells, creating a sort of a soft scaffold that is necessary to bridge graft. The second step is the bone-building cells that are the osteoblasts that lay down the mineral to change in order to change to bone the soft tissue. And the third phase is the remodeling. Well, quiescent mesenchymal stem cells become mobilized during repair and remodeling through regulation by external chemical and physical signals that are able to control their activation, proliferation, migration, differentiation, and survival. Look at the main step of the fracture healing. The initial pro-inflammatory response of the hematoma is characterized by hypoxia and low pH and involves several inflammatory cell types of the fracture site. But is essential step that during the subsequent repair process, the mesenchymal stem cells are recruited to the fracture site by growth factor and cytokines that are coming from the surrounding tissue. And you can look at this step in this very significant figure. Beginning growth vascular network is important for proper vascularization of the fracture gap. But the main step is that the mesenchymal stem cells start proliferating and differentiating into osteoblast lineage that are able to build up woven bone that's named collagen type 1 and cartilage that it should be collagen type 2. The third step, that is the final step, is the first step of remodeling that is characterized by a balance of hard callus, resorption by osteoclast, and laminar growth. And in this figure, we can verify the main step that allow mesenchymal stem cells to be recruited by surrounding tissue and that will be able to lies in the fracture side in order to starting the healing process of fracture consolidation and fracture mobilization. The physiological bone repair process is unfortunately impaired in delayed or non-union fractures as well as in aseptic burn necrosis. Although physiopathologic fractures are different in both disease, non-union and osteonecrosis, bone lesions are not repaired in the right time nor in the right manner. Several methods actually could be used in order to increase mesenchymal stem population and in order to lead this population to differentiate in this pathological area by transforming into osteoblast as well as an osteoblast. The main methods are actually four. First, a local injection of concentrated bone marrow aspirates works very well, but works at the same a primary culture of the bone marrow aspirate. In this case, culture should be used by resorting to adipose tissue due to the fact that its ability to transform in bone is higher in this solution, this situation, than resorting to bone marrow culturing. The third solution is a culture of the bone marrow aspirate to produce an expansion and an osteogenic differentiation of the mesenchymal stem cells. But the fourth, that is fundamental too, is a genetic modification of the injected mesenchymal stem cells in order to increase the secretion of the growth factors like B and P, bone morphogenic protein, and growth factor as DGF. We have just seen a slide like this, but this is fundamentally because I underlined this process that is fundamental in order to complete know the mechanism that is the background of the clinical application. Mesenchymal stem cells differentiation in the specific track, in this case osteogenic track, may be achieved as a result of environment, mechanical stimulation. The growth factor take up with platelet job and are able to stimulate the cells toward osteogenesis in this case. And the potential of multipotent cells is may consider it not only an intrinsic capability of the cell alone, but absolutely as the interaction between a cell with its physiological niche that provides the signaling working. And this suggestion of cell selection and expansion laboratory may be required as happened with the ACT, and consequently the transplant should be performed in only one operative step instead of two operative steps. So, stem cells or progenitor cells, as well as an appropriate extracellular matrix of support, is a scaffold, and growth factor and other solid proteins are the healing trinity that are able to start up, to perform the healing cascade that is devoted to the realization of the healing process. And the support, the choice of using the whole subset of medullary cells and to transfer the whole reserved potential to the lesion site. Look at the surgical technique. We start with the platelet gel production. 60 milliliters of the patient venous blood is harvested and processed, an example by spin, in order to provide 6 milliliters of PRP. After that, we start with the aspiration of bone marrow. And you can do this by performing a total 16 millimeters of bone marrow aspirate from the iliac crust in a supine position with the technique that we have just seen before. Biologic bone matrix is a very, very good practice tool that allow us to harvest with a very, very important flow reproducibility bone marrow aspirate. The other side that we have just seen is the side at the level of the upper part of the proximal tibia, just 2 fingers below the joint line and the middle face of the tibia. The main step after bone marrow harvesting is stem cell concentration. And the stem cell concentration is fundamental in order to get a high quality of the final product that should be efficacious at least for 7 days after processing. So, a DBM or a autologous bone graft or allograft scaffold is used for cell support. The scaffold is filled with 2 to 6 milliliters of bone marrow according to the surfaces and according to the depth of the graft, and concentrated and loaded onto the delivery device, which used to position the biomaterial within the defect. We have just seen this slide in which we have positioned into the tract the bone graft that was previously loaded by mesenchymal stem cells. It has been embedded in the mesenchymal stem cells, concentrated, and after that it has been activated with the growth factors we have just reversed from the venous blood sample in the first step of the procedure. And the post-operative treatment is a post-operative treatment that we have just before previously explained, but now we go to the explanation to clinical solution for non-union. In non-union, the etiology is actually not completely clear. Probably excessive mechanical instability of the fracture, a reduction of bone vascularity, smoking outside as more fundamental pathogenic fractures. But some genetic predisposition could exist too. But we know all that in atrophic non-union sites, osteoblast progenitor cells are significantly reduced in number. While most often heal with no complication, whether treated conservatively or surgically, about a ratio that pass from 5 to 20% of all fractures can result in delayed union or non-union. In this situation, based on animal studies, introduction of stem cells, and specifically mesenchymal stem cells, to the fracture site may promote or is able to promote the best bone healing and regeneration. What about the treatment of non-union cases? We well know that this treatment of non-union is a challenge for orthopedic surgeons. However, we have basic principles behind treatment in order to provide both mechanical and biological support to the non-union site. First, fracture stabilization and immobilization is used with the other treatment modalities in order to provide the biological support to the fractured bone. But biological support is fundamental too, and include the use of materials that could be served as a source of osteogenic cells. The term is osteogenesis, and these cells are the mesenchymal stem cells. But we need a stimulator of mesenchymal stem cells. In other words, osteoinduction is fundamental in order to get healing, and osteoinduction is performed by growth factors. But we need a third part of this healing process that is named osteoconduction. Osteoconduction is a scaffold-like structure named structural ligature. So that we look at the three main components that are the main actors for healing process in bone non-union. Bone union has been used to stimulate bone formation, bone defect in case of non-union, osteogenesis. Bone marrow can be aspirated, as we know, and concentrated in order to load the scaffold, or directly inject the mesenchymal stem cells, concentrated, aspirated, concentrated into the site of the union fracture. Because one of the possibilities is a percutaneous technique in order to enhance the possibility to improve or better increase the healing process without resorting to a surgical procedure. Growth factors are very important, and among the growth factors, we have a particular growth factors that is fundamental as osteoinductive potential in bone healing. It's named OP1, or human osteogenic protein 1. It has been cloned and produced with the recombinant technology and is free from the risk of infection or allergy reaction. Last but not least, we have the third component that is fundamental in the bone healing, that is the bone graft. The structural addition of bone graft is osteoconductive. It should be identified as collagen as well as calcium sulfate, calcium phosphate, all material that can be used to replace the lost segment of bone. Generally speaking, the graft we use for non-union is autologous bone graft that is generally considered the gold standard. The osteoconductive property of conchagas of graft is related to its porosity. A highly porous scaffold-like structure of the graft allows osteoblasts, osteoprogenitor cells to migrate easily into the area of the defect and to start up the regeneration of bone. However, harvesting the autologous bone graft is associated with the postoperative pain at the donor side and potential injury to surrounding arteries, nerves, and tissue, with the risk of infection. Thus, actually, the development of synthetic materials with osteoinductive properties are able to eliminate the need for harvesting, and it has become a major goal of orthopedic research. Allograft is the graft of tissue between individuals who are the same species but are disparate genotype, and has osteoconductive and limited osteoinductive properties. But DBM is a human cortical and cancellous allograft, and it has been prepared by acid extraction of allograft bone, and it has been considered one of the most important source of bone in the repair of small, medium defect. With a healing potential for healing potential of recovery from non-union that varies from 80 to 90%. If you look at this slide, you can verify that there is a different solution according to the potential of the different material you use for the filling of bone defect. The most important is autologous bone graft, but we have to look at OP1 for its possibility of great possibility of induction, and bone graft substituted for the possibility of osteoconduction, or the autologous bone marrow for its high possibility of osteogenic transformation. So that OP1 is considered in worldwide experience and all paper that you read all over the world as the gold standard for small gap and for defect filling. OP1 alone may be used so in the treatment of segmental bone defect, and its evidence is based only when we are treated on small size defect. Autologous cancellous bone grafting is considered, as we have just stated, the gold standard in treatment of long bone and unions, so that this procedure should be associated with complication of the donor as well as the recipient same, and the harvesting of the graft require always an additional surgical procedure with a prolonged hospital stay, with additional cost, with the risk of the vascularization. So that OP1, with or without the association of DBM, both are able to eliminate the risk of donor side morbidity, and as the additional advantage of decreasing cost, and that you have no hospital stay longer, because the procedure should be performed in 1 day surgery. This is an example of cases in which, after resorting to ASIF, as a plating, we resort to the association of OP1 and bone graft due to the fact that in these cases the defect was greater than 1 centimeter length. Friedlander studied OP1 and gave us the possibility to state that the patient, when receive OP1 and have the possibility to get similar results that you can have when you receive autologous bone grafting alone. But this is valid only when you have to manage a small defect that is a defect lesser than 1 centimeter length. Different cases explain the different success of OP1 versus autograft, and we do not want to underline this, but we can only verify that actually there is no significant difference between the use of autograft versus OP1. But OP1 should be used for greater gap, greater defects when, as I showed before in the previous slide, we resort to the association with bone graft, so that OP1 is typically applied in carrier or matrix late area, and is indicated in association with autologous bone graft in the treatment of greater defect. But what about the role, actually, of mesenchymal stem cells? Well, following the reports that Connolly and colleagues showed by percutaneous injection of the autologous bone marrow in 1999, where they showed a result between 70 to 90% of outcome, good outcome in longer bone non-union. Several investigators started up with the use of mesenchymal stem cells, the concentrated, aspirated, concentrated mesenchymal stem cells used in a percutaneous method in order to verify the possibility to get the best outcome in the healing of delayed non-union or non-union without resorting to surgical procedure. A lot of authors presented different studies with a different success rate that we can see go from 75 up to 10% of success according to the feature of the defect and according to the technique. In this paper, that is very, very important, it is coming from 2003 and 2001, we got a success rate varying from 68 to 75, but we went up 95% of success by in a fracture healed in a patient with a gap that was not more than 2 centimeters wide. And the case series are varying from 83 to 90 without discrepancies in the cohorts that have been enrolled in order to perform this kind of studies. A particularity is that OP1 versus the use of mesenchymal stem cells used in percutaneous injection works better than the OP1 tube. In the study, we have a ranking study scores for technologies, different technologies used for long bone non-unions. Well, in the study we can verify that the discrepancy between autologous bone graft, OP1 and mesenchymal stem cells is significant, and the resorting by autologous bone graft give us the possibility to obtain the best results only by injection technique. But when we were to manage non-union in which the defect is filled by fibrous tissue, it's quite complicated or quite impossible to obtain the same results only by injection. You have to perform the debridement and you have to fill the defect with the bone graft that has been loaded by mesenchymal stem cells. And this is the study we just managed some years ago in order to verify the possibility of healing of allograft by resorting to loading with mesenchymal stem cells in a pig model in order to verify how this kind of procedure works. And we verify that it works well and give us the possibility with all colleagues to go forward in this research and this clinical application. So that from percutaneous injection, we moved to surgical solution, and bone marrow concentrate application shown different protocols and give the possibility to manage the most used cases. This is an exemplified cases of non-union in a 37 years old female that came at our consultation 22 months follow-up from fracturing and plating. This is a case that we have managed in 2009, and we use at that time August method that is quite different from the nowadays method that we are using. But this is the alternative possibility that how now we manage in order to treat these cases while resorting to the system of Biologic. Well, this is a union, an important union. You can see at this level that this is a very, very important gap, and this gap is filled by tissue, fibrous tissues, and we have just harvested a piece of bone by bank, and after verify that the plate should be in situ without loosening of legs, we resort to a remodeling of the bone graft in order to fit perfectly between the two sets, the two stamp, and in order to position at the best in order to be completely avoided is mobilization. And this bone graft have been previously loaded by the mesenchymal stem cells that are loaded by the syringe, but before has been loaded by embedding the graft into a system in order to perform the most and the best embedding. Finally, there is the activation of the graft with the growth factor. And you can see that this is the positioning of the graft. This is the defect that has been completely filled using this part of the iliac crest, okay, that is able to completely be engaged in church's tongue. And you can verify at 40 days from surgical procedure that we have just the realization of bone callus that is able to maintain and to realize the structural continuity of part of the defect. But you can see in this CT and in this three-dimensional CT that the healing has been completed at 18 months follow-up. We go to another significant cases of the union. This is a female, 42 years old, that sustained a post-traumatic fracture of tibia, anterior left shaft, and we used in order to try to treat the best the non-union of the tibia metatarsal shaft, mesenchymal stem cells, più bone past, that is the BBM, associated più growth factors. And the steps are the same. We harvest the bone marrow from iliac bone spine. After that, we perform the processing of the bone marrow aspirate. And if you look at the slide, you can verify the proper solution with the fracture, and 2 months follow-up immobilization, and the failure of immobilization. This patient had been managed in another hospital, and he came at our vision with this kind of situation in which this screw interfered completely with the callus formation and is not able to maintain the good reduction that should be important in order to research to the outcome. So that we got a different solution, plating, internal fixation with angular stability, and we use in these cases DBM and mesenchymal stem cells in order to fill all the gap of the defect and in order to get the possibility to gain completely healing that we have seen at 14 months follow-up from previous surgery. Look at, give us the possibility to move another part of our speech. We speak now about the clinical trials in osteonecrosis. We can verify that there are a lot of study of femoral head osteonecrosis because this disease is not so rare, and according to different situation and different countries, it's occur in a ratio that is not less than 2.54%. When patients were treated before collapse, hip replacement was done in 9 of 130 hips, so that 6%. This is Ernigu, that was one of the most and one of the first report the result of study of femoral necrosis. In 2004, Genji showed a paper in which we have in the BM graph group the volume of necrotic lesion able to decrease up to 35%, but the survival was not so good. But we are moving to the present years, and in a Chinese publication 2008, we verified excellent good results in 75% of cases, and in 2009, Wang and colleagues demonstrated that the success was deemed in 80%, and hip replacement was made only in 7 out of 55 hips, that is about 12% of cases. The success rate with different technique move by from 70-80% to 85-82%. But we go forward because actually the gold standard for the treatment of osteonecrosis of the femoral head is, according to our experience, but according to literature data, core decompression associated to concentrate autonomous bone marrow. Not injected, but performed by a minimally invasive procedure. And this is the paper for which we have verified that results, even though the technique is quite interesting, are not always very good, but there are a lot of failure. 21% of patients underwent total lip arthroplasty because 16 out of 75 hip inefficient stage 1 to 2 after treatment failed. And this is a situation that is very, very important because even though most of treatment stated that in FICA stage 1 and 2 the healing process is up to 85-87%, actually the possibility to have a sure healing is not more than 92-94% in stage 1, stage 2, but decreased dramatically up to 45-47% when you have to manage efficacy stage 3, stage 3A or B. Well, in non-traumatic osteonecrosis, a vascular necrosis of the femoral end is a result that can lead the femoral end to collapse and generally is diverted to total hip replacement in patients young still. These are the causes that realize this situation. Apoptosis of osteocytes and cancellous bone leaving cells in necrotic lesion and also at some distance from the lesion in the proximal femur are increased. The regulative capacities of osteoblastic cells that are obtained from the intercancerous area of the femur are reduced in patients with osteonecrosis. The number of the activity of fibroblastic colony forming units that are reflecting number of mesenchymal stem cells that could potentially give rise to mature osteoblasts have been shown to be decreased in osteonecrosis. Moreover, the capillary swelling as a conduit for the stem cells and bone cells needed in bone repair, in addition to providing blood supply, could be altered by emboli or thrombosis in osteonecrosis. So, the possibility actually is that the treatment should be able to stimulate and to guide remodeling to preserve the integrity of the femoral head. We go further. We go faster, looking at our case series, in which we have enrolled 27 hips with vascular necrosis. And we have used aspirate marrow and concentrated platelets with graft factor in order to activate the mesenchymal stem cells in reconstruction of the scrotum. This is our results. Total hip replacement was necessary only in 4 cases out of 27 hips we have operated. 19 hips got complete resolution, but remaining 4 hips, that are 3 patients, that was located in stage 2 and 3, demonstrate improvement in clinical symptoms in comparison to the time before surgery, but these patients still refer functional limitation and pain. Look at these cases of that are completed cases. That is a female, 33 years old, with bilateral osteonecrosis, FICA stage 2B, in drepanocytosis. We use mesenchymal stem cells, bone pasta, with Prudence right system rim expander. We can see the bilateral involvement at the level of the classic zone of necrosis. And you can see in animal ray imaging the osteonecrosis that involve the 3/4 of the head. Also to the same solution, the step of the surgical procedure are steps that are performed by MIS technique, that is only approach of 3 centimeter length in order to have the possibility to manage at the best the canalization, the tunnelization, in order to arrive to remove completely the necrotic bone at the level of the head, and after debridement, with this step that you can see, that is performed by a reamer system, endoscopical reamer system, as a right system, the company, but there are different possibilities with these tools is performed by different companies. We have just, after the complete removal of osteonecrosis, we have used the combination of DBM with medullary concentrate centrifugation, and we just perform the positioning by pushing the material to fill completely the defect that has been realized with this kind of reamer. And this is the last step that we can verify in X-ray films, in which you can verify the complete filling of the head. We manage the same concurrently at the contralateral hip. The steps are the same, and finally the mesenchymal stem cells with DBM that have been positioned by joint injection just at the level of the fact that we are reamed and we are completely debrided. And 2 months follow-up, we can see early excellent results at CT scan, but plate film findings in patients with bilateral vascular necrosis in the femur who underwent this bilateral chordae compression. Despite treatment, an anterior-posterior film of the pelvis we obtained 6 months later show a flattening of the right femoral head. You can see in the black arrow. So we know the progressive increase in the size of the lucencies with the right femoral leg. We go further, and the last cases. This is a cases in which we can verify a very, very severe osteonecrosis with the completely removal of the bone within the lateral cortex of the epiphysis as well as the diaphysis, and due to the fact that the alignment is a malalignment, we try to resort to a step that allow us to look for the exact normal medullary channel in order to perform the implant arthroplasty in the correct positioning. After that, after the resurface of the femur that was completely out of cartilage surface, we fill completely all empty space with the mixing of DBM and allograft and mesenchymal stem cells in association. And these are the features at 3 months follow-up, early excellent result, and you can verify the completely filling of the metaphysics as well as the diaphysics in order to recombine or reconstitute completely the morphology and the functionality of this dam, in which we just obtain early experiment results of 3 months follow-up. So that the last slide, in order only to demonstrate that in all cases that we have managed, we have got very, very good results. And Biologic was also used not only in osteonecrosis, that is in osteonecrosis of the heel of the femur, but in osteonecrosis of the talus and the knee, and in bone healing disorders of different regions. The results, finally, with regard to subjective satisfaction, we got very, very good satisfaction of either subjective or objective situation. Pain reduction was achieved in all patients, no complication in the form infection, excessive new bone formation, or increase of complaint were noted. So that in non-union, gut results were found in all patients. In osteonecrosis, we have a problem because we can get very, very good results, but very, very good results as the choice treatment in stage 1, 2 of osteonecrosis of the femoral head because of the lack of potency when we have just got a flattening of the femoral head in stage 3A or 3B. Thank you very much.
Thanks.
What about? So we start with the second part of the day, in which we try to develop the core of day, and we deep into the main fields that we have developed for the treatment of osteoarthritis, as well as severe trauma or simple or complex trauma that are linked to micro-iterative traumatism. Well, this picture is a picture that's related to cartilage coin defects resurfacing by mesenchymal stem cells in sportsmen. As you know completely, there are some instances of cartilage injuries in sport. And there are sport arthritis risks that are linked to all sudden direction changes with knee or ankle sprain. This kind of sport typically involves football, rugby, volleyball, basket, skiing, and tennis. Or cartilage injury should be related to a single grade trauma, sprain, or a use for repetitive microtraumatism in athletic gesture. All of us know that cartilage has limited self-capabilities to repair. So that particular cartilage effects ultimately result in a chronic dysbiosis. But in order to contrast this world-class outcome, new reconstructive technique has been developed in the last 12 years. First of all, ACT, autologous cartilage transplantation. I started with autologous cartilage transplantation with the study of Lars Stevenson and Mats Wittberg in Malmö in 1992 up to 1993. After that, I moved from Sweden, and in Italy, I performed first autologous cartilage transplantation in a huge defect in May 1994. But ACT is a valid solution with a very, very good outcome, but get some problems. And these problems are limitation. And the greatest limitation is a two-step procedure in which you need to enroll patient to perform arthroscopic procedure in order to harvest a sample of cartilage in the notch of the knee, and in order to perform culture that will develop within 30 days. After that, patient have to come back in order to perform the definitive surgical procedure, that is the procedure that has been made in order to replace the defect by the use of autologous cartilage transplantation. So that today we have the possibility to bypass this problem, to overlap this problem, to resort to a new technique that involves one-step procedure instead of two-step procedure. And this technique is a technique that involves the use of mesenchymal stem cell without culturing. Because mesenchymal stem cells, you are able to differentiate into chondral or osseous lineage, as we have told in the morning, and they're able to feel completely the whole thickness of the defect by secreting through thick molecules. So, mesenchymal stem cells are proposed now as a new option for the treatment of cartilage defect because of their ability to differentiate into primary lineage, including chondrocytes. I've just shown this twice, 3 times, but it's very important to underline that in order to have a tissue degeneration, we need absolutely this healing trinity. Healing trinity that is performed by stem cells that are activated by growth factors and cellular proteins and are added to an appropriate extracellular matrix of support that is named the scaffold. And this supports the choice of using the whole subset of medullary cells to transfer the whole regenerative potential to the lesion site in order to gain the healing. So that the steps are the same we have just shown before. Platelet gel production is the first step, and is the first step that is used in order to gain PRP, that is considered the activator of mesenchymal stem cells or stimulator of mesenchymal stem cells by induction of this by transforming them in the exclusive lineage we would like to obtain. And growth factors, after their concentration, are able to increase over basal line up to 600 times in order to get enough factors, growth factors, to stimulate at the best mesenchymal stem cells. The second step is the aspiration of bone marrow. We have just seen before a lot of time, and last we have to perform the debridement of the defect in order to try to reach health borders, health boundaries, in order to gain health cartilage, and in order to replace the defect by shaping, by remodel the scaffold in order to gain the same shape, to feel at the best without any void, without an empty space, with the scaffold that has been embedded in the mesenchymal stem cells. And we can see that we can feel the scaffold. This is a yellow graft, or yes, is a YAF11. It is a hyaluronic acid-based scaffold. Its features is the possibility to gain complete reabsorption within 20 days, so that we leave only the mesenchymal stem cells that gain the ingrowth over the plate, and the base plate is bone, and in which, according to the indication of Max Rehberg, to try to perform further drilling, probably chondroplasty, in order to gain further mesenchymal stems coming from the deep of the bone. Last but not least, the activation. You have used mesenchymal stem cells, but mesenchymal stem cells should be linked to two possibilities: transformation in bone or cartilage. According to your need, you can look for reconstruction of the bone if the defect is the osteochondral defect deeper than 7 mm, or resort only to transformation by growth factors, for instance, desamethazoline or ascorbic acid, in order to realize the exclusive lineage in cartilage. I align cartilage naturally. And the post-operative treatment depend on several factors. Depend on the site of the defect. If the defect is located at the femoral joint, at the patellofemoral joint, you have the possibility to allow for weight bearing the day after the procedure without any problem, because we have no axial forces, but we have to avoid only the force that are cut force. And in case of involvement of the condyle, the femoral condyle, or the tibial plate, or both, naturally the weight bearing is not allowed at least for 30 days, up to 45 days, according to the size of the defect and according to the localization of the defect. In a kissing lesion, if a huge kissing lesion and you have no shoulder, you cannot allow weight bearing up to 45 or 50 days post-op. In case of a shoulder kissing lesion, that is a kissing lesion in which two defects are small defect and is contained by very, very good shoulder, you can allow for weight bearing up to 30 days from surgical procedure. And this is my personal case stories from May 2009 up to October 2012. I manage 97 patients. All patients were patient that was included in a Brickberg and Metz classification that is simple, complex, and solid. And of these patients, 70 out of 97 were sportsmen, and 46 out of 97 was treated for simple or complex coin defects. Now we are speaking about the possibility, about the procedure to treat simple and complex coin defect. Simple, complex, and salvage procedure is a classification that Tom Minus, a colleague of mine, stated in 2002 and differentiated in only simple, because there is only a coin issue that can involve any part of knee, for instance, or complex issue in which the defect is a huge defect larger than 3 centimeters diameter but is isolated, or plus defect more than 2 defect but contain a defect lesser than 1.5 2 centimeter diameter. And last but not least, the third is the salvage procedure. Salvage procedure is a procedure for which we would like to perform resurfacing despite of the necessity to resort to implant arthroplasty, uni or biuni or total knee arthroplasty. But in this case, salvage signifies that we tell patient and we suggest the patient that this is a possibility that can delay your new implant arthroplasty up to come. And in this case, question mark. And in this case, we explain that we can gain a healthy state without any complication for at least 4 or 5 years. But we are not sure that this can last more than 6 years. Fortunately, our case series demonstrated that we have the possibility to gain healthy state up to 15 years from this procedure, and in this way we have the possibility to document very, very huge cases that up to date works very well with a complete regain of the normal functionality of the knee as well as of the ankle as well as the hip without any pain, without any suffering. So we are studying this 46 out of 97 patients that are sportsmen of high or medium high level, are professional sportsmen, and this patient have been treated by this kind of surgical procedure with one step mesenchymal stem cell, and the whole procedure has been recommended according to a protocol that we have stated with the ICRS and ITDC according to more curve scoring system according to the LQLAQ5 dimension. Look at the first cases. This is a small coin lesion that involved patella. It is a simple case. The first procedure is the harvesting of the bone marrow. After that, you can verify. This is a simple coin defect in which you can verify the defect is not so huge, 2 centimeter, not more than 2 centimeter for 1.5, and after the procedure, the treatment, and after the cleaning of the defect in order to leave the intact border of earth cartilage, we shaped according to the shape of the defect with the scaffold embedded in this bone marrow concentrate. And finally, we use the fibrin glue in order to seal the edge of the defect and activated at last with growth factor. And this is the outcome. This is the outcome at 12 months arthroscopic time, and follow-up time was 24, 2 years. And you can see, according to the IKDC report, evaluation score of about the maximum, 96.5 out of 100, with mean functional grade of normal and ISRS cartilage repair assessment of 12 out of 12. If you look at the NMR imaging, you can verify that the defect is completely filled by native cartilage, and you can verify the boundaries, but boundaries are without continued dissolution. The functionality is completely good. And at the second spectroscopy, you can see that cartilage differently is difficult to differentiate from the earth native cartilage. Is only lighter, softer, and you can verify that an MRA imaging at 12 months follow-up, we have gained completely reconstruction of the defect. If you look at the histology of these samples demonstrate the maturation of the implanted mesenchymal stem cell to a clear fibrohyaline-like phenotype without actually peculiar cell organization. And if you look at another case, we are speaking about a complex case. This is a male, 28 years old, that sustained an important defect that involved lateral femoral condyle. And if you look at this slide, you can see that the defect is 4 for 2 centimeters. It's a very huge defect. There is a small point defect of 1.5 to 1.5 at this level, but the most important is this huge defect that you have to completely reconstruct by graft. Well, you look at the arthroscopy time is at 18 months, and follow-up time 18 months, and we have gained completely functionality. Patient resulted is previous sport disorder, yeah. And if you look at the second arthroscopy, you can look that we have no zone of completely uncovered cartilage. Cartilage cover completely the condyle, and it's quite difficult to differentiate the reconstructed zone to the adhesions and native cartilage. And if you look at the third arthroscopy at 18 months follow-up, we can verify that now we have a stage in which we can verify immunoorganization at the best of collagen type 2. This is collagen type 2 at greatest. That is 80 to 90% of collagen type 2. That is cartilage, pure hyaline cartilage. And you can verify this when you look at gag staining, and this staining for gags chondrocytal embedded. Look at this, chondrocytal embedded into a lacuna, and cell clustering throughout the specimen, probably undergo alignment. Hyaline cartilage, well matured. The third case is another simple case. We differentiate this case from the other due to the fact that from open approach we can move to arthroscopical approach without any problem. This is the medial femoral condyle in a young male that play in a B Serie A football league. And these are the steps that you are using in order to gain the outcome we are looking for. The lesion, and debridement, and after that, with different tool, different instrumentation, the possibility to replace without the open approach or mini open approach of the coin lesion, and this is immediately post-operative outcome, and this is the second loop arthroscopy. We can verify that the cartilage has completely recovered, but it is softer than in other cases. But patient gained completely its functionality, and at second loop arthroscopy at 14 months follow-up, we got a subfibrillation score of 97.5 with knee functional grade that is normal, and cartilage repair assessment that looking at the second loop arthroscopy allow for verifying after the sampling we have taken that is a good eye that is still remodeling and maturing due to the fact that it is only at the 14 months follow-up from surgical procedure. But gap deposition in collagen type 1 are very, very abundant in this specimen. So we analyze the case of service, and we can verify that the broad patient, was up to 86.3, and in relation to the lesion size, we can verify that we got best results in lesion in defect greater than 4 centimeters, square centimeter, despite of lesion that are confined only to 2 to 4 square centimeters. And if you are looking at pain, discomfort, and mobility, you can verify that statistically significant improvement has been in pain reduction as well as in mobility. And when you approach the examination, you can verify that the knee examination state in the report as a normal or normal knee. That is 95%, 0.3%. If you are looking for a Mokat scoring system, we can verify very, very important situation. Complete filling of the defect found in 92.5%. Complete integration, 94%. Intact subcontract lamina present in 84.6%, and intact subcontract bone in 76.5%, with average value, average score of 78 out of 100. These are very, very important results. But looking at grid barrier score, the score for endoscopic evaluation, we can verify that the mean score is 11.4 out of 12. A very, very good endoscopic score. But if you refer to second look at biopsy evaluation and you refer to histological analysis, you can verify that in these cases, IL-like samples were in 4 cases and a mixed tissue or fibrocartilage tissue in 1 case. With integration with subchondral bone in all cases, you can see this is the dye mark, and it's completely integrated with bone and cartilage. So the preliminary conclusion, we got no adverse events. Clinical symptoms decreased within the second month post-op with good recovery, significant improvement of range of movement. If you look at the 2 possibilities, the management of the procedure by ACT or by mesenchymal stem cells, in the early maturation, we can verify that the maturation of implant by mesenchymal stem cells goes to a cloud fibrillary-like phenotype, but without capital cell organization, they need more time, and you can get this outcome up to 18 months, 12 months. So, the preliminary conclusions are that we need to verify the results at 3 as well as at 5 years in order to appreciate if the quality of reconstructed tissue are maintained and the improvement of the cartilage quality is deteriorated or is stable. Finally, if you want to differentiate the two procedures, we can verify that in the early stage, mesenchymal stem cells are very, very adapted, very proud for lesions that are simple, shoulder and point lesion, larger than 2 centimeters. And ACT should be the best solution in larger defect, in greater defect. But according to the scaffold we are using, now we have overlapped this solution and we are able to resort to a scaffold that is able to transport the mesenchymal stem cells and to allow for complete integration while leaving the mesenchymal stem cells as a tapestry to cover completely the huge area, even though it is more than 3 or 4 diameter, 4 centimeter diameter. So that for the twin and cartilages midpoint defects, we can verify that no adverse event was got, remission of pain and swelling was completed, and there is an overlapping outcome versus ACT procedure. But we have used a single operative step with important cost reduction. And we speak about the cost reduction just in the further speech. Thanks. Someone want to raise a question, no problem at all. Alternatively, I go to first question.
Now, when you put the graft in you don't have to cover it with periosteum as we used to do before.
Absolutely not. Periosteum flap was first realized procedure that must be very stated in 1993 with Lars Peterson. After that, orthopedics field passed to second generation and third generation. Second generation was the possibility to resort to cover without the use of periosteal flap by only the use of a scaffold that is embedded with mesenchymal stem cells or culture. And the third generation is a new scaffold in which you have the possibility to adhere completely to the defect without resorting to sealing tube. So the second generation scaffold is a scaffold that allows to avoid the use of periosteal flap raising, and in these cases you have the possibility to manage of the best your defect, because the defect that is covering with the periosteal flap need to be completely filled by the injection of the cartilage cells, the culture cartilage cells, but that are in a liquid fashion. Now we use a solid solution, and in which, in this case, we have the possibility to overlap all the problems that were linked to this kind of procedure. For instance, release, rupture, breaking out, loss of periosteal flap, a lot of complications. Last but not least, the most important what a complication or the hypertrophic situation that we can manage or we could manage when we manage with the periosteal flap, because periosteal flap can degenerate and can transform itself in a hypertrophic flap that was only a cover of the defect that not completely was able to ingrow the bone. Yeah?
How much the procedure would cost for a 1 point defect person?
How many possible? How many?
One single one.
One single?
Single point defect you have.
Yeah.
How much it would cost for the procedure?
Well, when you have to manage a coin lesion,
Yes.
you manage coin lesion without any limitation. Even though coin lesion is wide, but coin lesion is shouldered, you have no limitation. When coin lesion is wide and greater than 2.5 diameter centimeter, in this case we resort, according to Max Friedberg, to private drilling in order to allow for further flow of the mesenchymal stem cell that came in from the depth of the bone. But there are no limitation of diameter of the lesion, of the coin lesion is a simple unshouldered. When the lesion is a coin but unshouldered, you have to resort to a different solution. The different solution is that to try to perform a notch in order to give the possibility to the scaffold to be completely adapted to a shoulder in order to avoid the slipping of the graft during the movement that start passively the day after the surgical procedure.
No, I meant how much cost money?
Oh, now I can show you the outcome and I can show the cost. If you speaking about the cost, the completely cost, a procedure that involved ACT in Italy, as well as in Germany, as well as in France, costs about 12 to 14,000 euros. When you resort to arthroscopical procedure, the costs are varying from 9 to 12,000 euros. But if you resort to one-step procedure, that is one-step procedures linked to mesenchymal stem cell procedure, one step, they need only from 4 to 5.5 thousand euros. But in other situation, the possibility should be related to the use only one instead of 2 or 3 scaffold. And the real cost is the cost of the scaffold, because due to the fact that mesenchymal stem cells need only a centrifuge, not more, and a disposable tools that are not so expensive, we have the possibility to confine the total cost of one procedure is a simple or coin lesion to 4,000 euros. I speak about euros. Well, if there is someone interested in a reply or question, alternatively, I move for the most important part of the speech of today, that is the speech related to the use of mesenchymal stem cells in osteoarthritis. This for me is the most important part of the speech that we have on today, due to the fact that this is the procedure that involved me completely since 10 years, and then I have developed with some colleagues as Tom Heinas as well as Brittberg since 7 or 8 years. But we have performed further improvement, and now we are able to treat severe osteoarthritis form as occurs in case of need of uni is unicompartmental osteoarthritis, or in cases of severe osteoarthritis of the ankle. If you move to these topics, we can anticipate that the reason that the broken cartilage of the knee and calves are unfortunately extremely common. Their origin, as we know, is traumatic in nature or degenerative, and early therapy is important because untreated lesions have the tendency to become chronic, and the damage could be or should be reversible, leading to chronic symptoms and osteoarthritis with a share ranging from 70 to 50% of cases. There are different papers involve different journals in which are investigated the incidence of osteoarthritis after meniscectomy or after simple arthroscopic procedure. But as you know, there is a main fundamental paper of a German surgeon that by investigating 17,000 arthroscopic procedures, they found that in 36% of cases has been completely involved knee in one or two compartments in order to realize in 19% of cases a very, very huge osteoarthritis, just staged 2 or 3A. So that the problem of osteoarthritis is very, very common, and this is the reason for which all surgeons, or most surgeons, are interested in trying to realize or to try to solve at the best the problem of these young people. We know well this slide, and now we perform a comparison between the two solutions, ACT and mesenchymal stem cells, in order to verify the advantages and disadvantages. In a yellow-based tissue engineering, by the use of biomaterial derived from hyaluronic acid, for instance IF-11, we can realize an ideal three-dimensional scaffold for the cultivation of human polychromocytes, giving the possibility to restore the differentiated phenotype by maintaining chromocyte capability to produce collagen type 2 and proven and simplified implant technique. The bioengineered tissue, by due to the three-dimensional structural and physical properties that is very close to the lost cartilage, is able to realize an optimal filling of the tissue gap, stable or large piece of defect, by resurfacing of completed equal surface. In this case, if deformity requires realignment procedures, we resort to uploading on corrective osteotomy that usually can be associated when the deviation is quite important. So that we are speaking about salvage procedure, and we are speaking about the treatment of the salvage procedure. Salvage, according to Dominus, are possibilities in which osteoarthritis is held at stage 1, 2, up to 3, or kissing lesion in which we need concurrently to resort to the alignment procedure as well as ACL reconstruction prior to do bone grafting or cell. Or actually, we can do simultaneously this kind of procedure. So that in patients younger than 55, 58 years old who want to avoid or delay uni or biuni or total arthroplasty and strongly require as alternative resurfacing, ECT has gave very extremely promising result. And look at this case. This is quite important. This is a female, 55 years old, suffering by kissing lesion. Well, in this case, we can find that we have tibio-femoral alignment not more than 8 varus, but the used situation is that there is a kissing lesion involving complete femoral condyle surface as well as complete tibial blade surface. So that in order to gain earthy state or to improve the solution, we have performed first a realignment procedure according to good technique by use the plate in order to restore the joint line, tibial joint line. And this is a particular of the kissing lesion. These are the steps that we have documented in order to implant the plate after the osteotomy, tibial osteotomy. After that, the steps are simultaneously the use of blade, or the use of the osteotomy, to net, to cut, and chop away the edge of the cartilage, but you can verify that in this case there is no shoulder. So that we have to resort to create a formal shoulder by a notchplasty in which we use some mining anchor in order to have the possibility to stabilize the graft. This is the mini anchor. And we have completely covered the defect, and after the release of the tourniquet, we can verify the bleeding and we can verify the complete inflow of the graft, either at the tibial level as well as at the femoral condyle. And this is the X-ray fields. And if you look at the 12 months follow-up, you can verify that there is a complete restoration of the defect with uniform cartilaginous resurfacing, even though we can find some cartilage fibrillation areas. At 12 months follow-up, we got quite good results that should be cartilage repair assessment 12, mid-functional grade nearly normal with 85.1 score on subjective evaluation. But look at this. This is the histology. And if you look at the time mark, if you look for the time mark, you can verify that there is a perfect integration with the subchondral bone, and the abdominal chondral collagen type 2 relies a hyaline cartilage is almost completely mature, with a realignment of chondrocytic columnar way, columnar fascia. But, last but not least, 10 years follow-up. I reviewed patient 10 years, and we can verify that despite of the problem in which you can see that there is a narrowing, line narrowing of the space in which we have performed osteotomy, in which we have opened the space, we have gained nearly normal functional grade, a 92.3 subject evaluation score with quite good, not excellent flexion. It's the same flexion that she gained just after 1 year from the procedure, and without any pain, and patient is gaining normal daily living activity, previous work and sport, getting a job. So, we try to analyze the 29 cases of unicompartmental involvement, osteoarthritis involvement, that we have treated by this procedure, ACT in kissing lesion, with the total surface implanted of 12.3 plus minus standard deviation of about 4 square centimeters. All cases are treated and managed in Outbridge degree stage 4. If you look at the efficacy results, and this result was verified at greater than 8 years from surgery, we got statistically significant improvement that have been maintained from baseline. This is 96 months, and this is 44.8 months from surgical procedure. We can verify that there is a statistically significant improvement that have been maintained from baseline at the 2 cohorts at 44 as well as at 96 months. And looking at the arrow curve, pain discomfort as well as mobility statistically verify improvement that has been maintained from baseline in both procedures. But in some cases, we lost the patient by biological point of view, and we need to transform reconstruction, a biological reconstruction performed by HEP in torsion angioplasty. Why? This is are the cases, 2 cases, one or 2 cases are linked to the fact that we resort to low femur osteotomy instead of high femur osteotomy, because this was a valgus knee. And the management of valgus knee is more difficult than the management of valgus knee. And there are a lot of situations that can explain why this procedure failed at about 8 years from implant. But we stated and we told that this was a salvage procedure, and the patient is very happy too, due to the fact that they delay the total knee angioplasty up to 8-7 years. 79% of patients that experience this kind of procedure maintain improvement in immune function and symptoms. And they got no pain, mobility problems, follow-up. And 91% of treated meat classified as normal or near normal, according to IPDC mean objective evaluation. At the first follow-up, midline follow-up, the repair tissues will be classified as normal or near normal in 100% of cases, all cases. And repair tissues has been classified as an hyaline cartilage in the greatest part of samples, with only limited number of complications due to the fact that great failure was observed in 2 patients out of 29, and they were obliged to transform in totalmente. So, theoretically, due to the right-timeness of the subjective and objective clinical results, none or only mild degeneration of the myocardial surfacing tissue should be approved. So, IR1C, for instance, ACT, overall concurrently with the alignment procedures, should be considered safe as well as effective therapeutic option for the treatment of unicondylar osteoarthritis of the knee. And the paper of Tomanis, as well my communication and my paper in 2007, stated that this case series and this kind of procedure should be reproducible and should give patient the possibility to delay at the best, at least 7-8 years, the possibility of resorting to angioplasty. But what happened with mesenchymal stem cells? Mesenchymal stem cells are actually the proposed new option for the treatment of severe articular cartilage defect. We go forward this step, surgical techniques I've just seen. We have just seen a lot. We move fast and fast because we have used the same slide, and we go to the case series. Well, from June 2008 to December 2011, we implanted mesenchymal stem cells arthroscopic or mini-open procedure in 31 patients affected by Harback stage 2-3 for medial and lateral intercompartmental femorotibial osteoarthritis using concurrently HTO or LFO, high tibial osteotomy or low femoral osteotomy. Patellofemoral joint osteoarthritis are managed in 18 cases and 6 unshouldered kissed ankle large defects have been managed. The average age was 32 years, and the mean size of the lesion was 9.5 square centimeters, with a range that can from 5 and goes up to 27 square centimeters. All patients were followed an average follow-up of 24 months, 2 years at least. And now we move to document the cases. This is a very, very important missing lesion in a 44 years old male. These are the steps that we previously, with the last technique, with the use in order to harvest bone marrow and concentrate on bone marrow, and look at the size of the fat. It's involved 3/4 of the patella, as well as we can see, but if you switch off the light, you can verify that there is a huge lesion kissed at the level of the trocar. chocolate effect in the medium part, that is our maximum grading of the maximum movement of the crest of the patella, and the step that we have used in order to restore and reconstruct completely the effect at the level of patella here, as well as at the level of the trousers. Look at this. Can you switch off the light, please? Because it's very, very important to document. It's quite impossible. It's very, very difficult to verify where are the boundaries. Oh, sorry. Where is the boundary? Where are the boundaries of the reconstructed tissue? We can only verify due to the fact that there is a different matching in the grade of the gray, because in native cartilage by mesenchymal stem cells, the grade of the gray is lower than in the normal cartilage, and this occurs at 6 months follow-up. At 18 months, we have a situation for which mean functional grade as well as cartilage repair assessment and some deterioration score of the normal mean. And the patient didn't want to be submitted to second look arthroscopy. They stayed too well. And we perform a new NMR imaging, and in NMR imaging you can verify that there are no windows. The defect is completely healed with a score of 95%. We taken percutaneously a sampling of the cartilage, and without resorting to arthroscopic procedure due to the fact that the patient didn't accept, and we can verify that we obtain a very material cartilage with strong lymphocytic position and columnar chondrocyte rearrangement that is typical of pure hyaline cartilage. This is the second example of cases, the Biologic case in a skier, professional skier. This is a trainer who has been a trainer of national Italian ski team, A ski team, and due to the fact that he was 30 years, he became a trainer, but he suffered from this huge dislocation that involved medial femoral condyle as well tibial plate. And in this case too, we resort to tibial sclerotomy, and we can verify at animal imaging a very, very good result of this level, and he regained completely his functionality. He's a trainer of the national Italian ski team. And second look allow us to appreciate a very, very good reconstruction with uniform cartilages resurfacing and no milking and probing at the level of the tibial plate too. That is one of the worst places in which you can verify an arrangement of reconstruction cartilage. And now we move to other two cases There are massive involvement in entire bone and tibia, and osteoarthritis is secondary to fracture bimalleolar or trimalleolar fractures, was a trimalleolar fracture. And in this case, we use a personal technique I issue in different papers as identation technique. In case in which you have no possibility to get shoulder, you have to find shoulder. And in order to find shoulder, you create your shoulder by performing a dedentation of the bone not more than 1.5 millimeters deep, in order to have the minimum of shoulder and able to contain completely the scaffold that has been abandoned with mesenchymal stem cells concentrated. These are the steps. You can see the scaffold that has been retained and shaped according to the defect that we have created. It's completely loaded by mesenchymal stem cell, by the bone marrow concentrate, and you can verify the first and the second and the tibial bone. And finally, the result, the complete activation of growth factors and the total reconstruction of the defect in order to gain two surfaces able to run one over other without problem. But look at this. The score is quite good. 85. 85 with a complete feeling of defect. A complete integration of the border zone to the adduction cartilage. Intact homogeneous tissue repair, subcameral lamina, subcameral bone, almost integrated. And the score was a score normal and 92.5 the score out of 100. We have a video that doesn't work, unfortunately I proved this morning. We move to other cases like this. This is a female, 45 years old. You can see the osteoarthritis involvement that are completely destroyed the joint line. We have removed the lip, anterior lip of tibia as well of the osteophytes of crown osteophytes of the talus. Bone harvesting, bone marrow harvesting, absolutely. And the steps in order to reconstruct it the same way with identation technique. You can see I use a scalpel in order to realize identation, and I would not deeper than 1.5 millimeters. The restoration of the surface and animal imaging. The score is 87. Patient gained quite good functionality in the whole movement of the hand. And this is an application of it. I have no possibility to movement. I can see. Look at this. This is the visibility. This is the part of the cartilage. This is completely filled by mesenchymal stem cell as well as at the level of the tibial valve. Last but not least, what you can do when you have to manage a problem like this. In this case, most of colleagues of mine should resort to a total arthroplasty. But look at this. ACL is fantastic. And due to the fact that we want to maintain proprioceptivity because proprioceptivity is fundamental in order to maintain your functionality, your sensation, your feeling. What do we do? Well, it's impossible to resort to a huge region, so we resort to hearing compartmental. This is a sample. But we recreate the notch in order to harvest bone marrow. This was one of the first procedures I did with this technique. And we reconstruct completely chocolate as well as patella, because now I show you patella. This is the fact of patella. And we reconstruct chocolate as well as patella, and we completely restore the contouring, the morphology, the alignment of the two situations by healing. This is the left side of the knee, the other knee, because we have performed this procedure simultaneously in both knees. In this knees, we need only to swatch the common region, shoulder, as well as of the patella. I'm sorry. Okay. Without moving, but they don't move. But for the post-operator, these are moving. I don't know why they don't work. But the patient at 14 days from surgical procedure actively move, actively work without any pains. We have reconstructed the patellofemoral joint. This way is not fundamental after a rest of 10 to 14 days to try to save movement and to try to protect movement. This video works, and you can see that both knee is able to flex completely your joint. We're going further, and the last cases that is quite interesting because this is a 43-year-old man with a very huge valgus knee and with a problem of involvement of the unicompartmental fascia. So that we try to reconstruct the best two knees simultaneously. You can see the X fascia of the two knees. And these are the used and the worst case we can manage on. You can see that there is no absolute cartilage in every zone. And so we verify that the ACL is not fantastic, but it's integral. And in this way, we perform a B-uni. And with B-uni, we treated as well trochlea, as well patella with the stem cells. And we got B-uni. We use mesenchymal stem cells injection in order to refresh and to try to regenerate the best ACL. I injected it inside the fibers, within the fibers. And you can see, but we have resurfaced small lesion at local level as well as at patella level. And this is the left knee, in which we resort to unilateral uni and patella resurfacing with mesenchymal stem cells, can cure it. And this is the result X-ray film. You can see the right and the left knee with the uni, with the ACL. And I hope that this works because it's very important. This patient okay. We are speaking about 16 days post-op. Is low, but this is natural working because we have completely left the proprioception, his proprioception. And this is a 21 days follow-up. You can see that patient is able to rise to the Duchenne stern. And she didn't implant a total angioplasty. If you look at the cases analysis, we go further because we can verify that we got a normal or quite normal situation in a kissing vision tube. And in alpha score, the score that is devoted to evaluate the ankle, we got improving at 84% out of 100. That is a very, very good result too. So that a single partner alpha improvement was found with the 3 different techniques: open, partial, and bone marrow treatment. The error pool, EQ5, showed a very, very good situation with perireduction motility restored. And if you look at the different parameters of the MOCAT score that have been evaluated in the final follow-up, we can get an average value of 81 out of 100. This is fantastic. Braided core 10.6, and for sample analysis instead of 6 of the ACT procedure, with the same result. But if you compare mesenchymal stem cells in unicompartmental or bicompartmental osteoarthritis versus ACT, in which we follow and we perform the same surgical procedure, we obtain a more, not significant, but more improvement in this procedure. 84% maintain improvement in knee function and symptom. 95% out of 99 versus 60 as classified as normal knee. At 12 months follow-up, repair tissue has been classified as normal or by normal. Repair tissue has been classified as a line cartilage in most of the cases. This is overlapping or ACT. But in this case, we have performed only a single operative step with consequent and important cost reduction. And now I can show you 14,000 euros for open field HET. Arthroscopical HET about 10,000 and 4,000 and about 400 euros for mesenchymal stem cell procedures. Thanks.